Welcome everybody to the second session. This is the wonderful Nadia Bhal here, who is a gynaecologist in Wales, who works in the NHS and in her own private practice as well. And she is going today talk us through prolapses and the pelvic floor and all of those sorts of things that tend to happen to more of us than you actually think. Around about 50% of people, I believe, Nadia. Is that what's the sort of incidence of this that we see?
Well, about 50% of women will have some degree of prolapse. And in my practice, I find that women who do present with prolapse have had some form of a pelvic surgery. So hysterectomy can commonly lead to prolapse in the future. So what I've done today is slightly different than yesterday because throughout my career, I've always done a lot of teaching, a lot of education. And a couple of years ago, I went to West Wales and I gave a talk to quite a group of nurses and healthcare professionals. And just kind of, they wanted to have some insight into prolapse. So I've actually used that talk today. I went through it. I don't think it's heavy medical. But if there's any terminology that you're not quite clear of, then, just put your hand up and ask me questions as we go along. My aim is to help you as much as I can. Also, if you'd like to have a copy of the slides, I'm not precious about my slides. I'm happy to share them and, you can share them with your friends or, have over a glass of wine or something. So if you want to. So I'm going to share my screen and you'll see. And actually, I'd like some feedback if you think that this is a good format to use for us to kind of use in the future, or if you feel yesterday was free flowing, that was better, then I'll go back to that. Right. Okay. So what I'm going to try and cover tonight is, what is prolapse, why it happens, how common is it? As medical professionals, particularly working in the field of urogynecology, prolapse incontinence is heavily governed actually by all the governments now worldwide, especially after the mesh scandal. So I'm going to touch very briefly on some governance issues that you may be interested in, and then what types of prolapse is it possible to have? And I've got a few bits of models that I can show you with regards to treatment. So prolapse itself, it can be seen as a sign. So when something is quite visible, usually I would say as a woman, you're probably going to have a symptom before you see a sign. And the symptoms that the most commonest symptoms that I hear from women, and as I mentioned yesterday, my passion has been the pelvic floor for the last 24 years, is something coming down. That's a very common symptom of a prolapse, where you feel a heaviness in the vagina, and most women will understand what that means. I can feel something coming down, or I feel as if my insides are falling out. I feel a heaviness in the vagina. Another common symptom that women tell me is I feel like I'm sitting on a ball and I have to shuffle my bottom around or kind of try and get comfortable, as if, and what they're obviously doing intuitively is pushing the prolapse back up to where it should be. Another symptom is you're on your feet all day, especially I see people who are like teachers, people who are working in face fronting kind of jobs, where they start noticing the symptoms start coming on towards the end of the day. And that's because of gravity. Obviously, you're on your feet most of the day. You go to bed, the prolapse goes back up to where it should be. You carry on throughout the day and the prolapse starts to descend towards the evening. So that is a very common symptom. Now, there are other symptoms associated with prolapse, and it really depends on what type of prolapse you have. You will have different types of symptoms. So the ones that I've mentioned earlier are kind of universal to all the different types of prolapse. So you've had these symptoms, and not everybody's comfortable looking at their vaginas or examining their bits, but maybe just have a look. If you were to sit kind of with your legs akimbo on your bed, put a little mirror down there and cough or bear down as if you're pushing down, if you have a prolapse, it will become visible maybe at the entrance of the vagina. And you'll see it as a bulge. Don't be scared. That's all it is, actually. It is a weakness in one or a couple of areas of the vagina, which is leading to basically a hernia. A prolapse is nothing more than a hernia that's happening within the vagina. You may also see, as I mentioned yesterday, that little cherry at the urethra. That's a sign of lack of estrogen, but that is also a form of a urethral prolapse. So the lining of the tube between your bladder and the outside is lacking estrogen, and it kind of pops out and gives that urethral prolapse, which is known as a caruncle. So sometimes another symptom that women say is that they find it uncomfortable when they have sex, or they feel that something is in the way, or, you know, most men are quite sensitive. They won't say, darling, your vagina feels odd. They're not going to say that, but, you know, they may say, you know, I feel as if I'm knocking something or I'm hitting something. Most commonly, that's the cervix. If you haven't had a hysterectomy, because the cervix is quite firm, it's like, it feels like your nose. So we always say, if you want to know what a cervix feels like, it feels like your nose, the tip of your nose. And so if your husband or your partner or mentions that they can feel something, then it probably may be a prolapse. But commonly, it's not painful. If a woman comes to see me and says, my prolapse is painful, I haven't had sex for years, prolapse itself is usually not painful. It can be uncomfortable because there's a bulge, but if it's painful, then I'd more be thinking along the lines of atrophy. There's lack of estrogen in the vagina. The vagina just is lacking in estrogen, which makes it uncomfortable. So those are the main symptoms, and a sign would obviously be the bulge. That could be within the vagina or outside the vagina. So those are your symptoms, your signs. And if you were to come and see your GP or your gynecologist, a urogynecologist certainly would use something like this, which is called a quantification system, POPQ, or you may have heard it as the lollipop test, where we have specific points in the vagina. We would we would do these measurements when we do a vaginal examination, put them into this table, and it would come up with the type of prolapse that you have. And I will cover the different types of prolapses and what to expect later on in the talk. So why? Yesterday, I think we spoke about prevention. Prevention definitely is better than cure, certainly with any form of surgery. We always say, as a mindful surgeon, is that the most difficult surgery to do is not to do surgery at all. So I would personally, although I love operating, I'm in my moment of bliss when I'm in theatre, but I also am very mindful that if we can avoid surgery, that is better. So the reasons why, the main causes for prolapse are very similar to the main causes for incontinence. Again, childbirth. So pregnancy itself is a cause or a risk factor for prolapse, but what makes childbirth more of a risk factor is actually these. So for anybody who may have had an assisted vaginal delivery, these are forceps. And forceps, in my opinion now, after having spent quite a few years really specifically looking at the pelvic floor, are probably the most damaging instruments to the pelvic floor. So these, I was just explaining to Fiona, these are what we call a low outlet forceps. These kind of, if the baby's very low down in the birth canal or at cesarean section, if the baby's needs a bit of a hand or the head is quite low, we would use these type of forceps, but you could see they're quite wide. And it's no wonder that putting these instruments in the vagina would shear off the muscles off the vaginal wall. And once we shear off muscles off the vaginal wall, you can look at this picture here, the outlet to the vagina is quite small. So if you have a big head there and you add on the forceps, what's going to tear are these muscles here, the muscles around the vagina, the bulbocavernosus, the puborectalis muscle. So the muscle that comes from the pubic bone, comes all the way down, goes around the back passage, goes back up to the other side. Once those are torn, there's not much we can do about it. They will obviously, if you can imagine, if they tear from the top and they drop down, the vagina itself becomes wider, and there's nothing there to hold the insides of the vagina up. So you go from having a diamond shaped vagina to a teardrop shaped vagina, and there becomes a weakness there, which kind of contributes to prolapse. So childbirth, delivery, as we get older, lack of estrogen, so the menopause doesn't help. Again, as I mentioned yesterday, the weakness in the muscles there. So that's why it's so important to learn how to do pelvic floor exercises early. And I think that we should be teaching it to our children, how to contract the pelvic floor from a very young age, so it becomes something that they do habitually and they take it through to their adult lives. So pelvic floor exercises as we get older, age alone. Once we start going over the age of 40, our muscles are not as strong as they used to be. So again, it's important to work on that pelvic floor. We spoke about obesity, 2 factors here. The fat globules in the muscles themselves make them weaker, but also the pressure. And as we go through the menopause, sadly, that middle age spread is a fact. We collect fat in our bellies, which makes more pressure on the pelvic floor. And then heavy lifting. So if you are lifting heavy objects and not using the right posture. So before I came back to work in the UK as a consultant, I spent some time as a care assistant in a nursing home, which not much people know about, because I had to do my degree all over again, even though I'm British and I can speak English, but I had to do everything from the beginning. So it was really important to learn how to do your posture correctly. So if you are certainly a carer and you're looking after an elderly parent or anybody at home, how to bend your knees when you lift, how to look after your back, because our core muscles need to be strong to help avoid prolapse. So the pelvic floor has quite a lot of functions. And if you can see here, this is our pelvic floor. Our pelvic floor, and particularly our puborectalis, our rectal muscles, are probably the strongest and most important muscles in our body, because they keep us continent of urine and feces. If we have very weak pelvic floors, we become incontinent. They lead to a kind of protective mechanism, a protective reflex. So when I look after women who've got severe vaginismus, especially maybe those women who've had a traumatic event as a child or as a teenager, their first sexual experience wasn't great, they will develop a degree of vaginismus, so that the pelvic floor contracts to protect. When we have a strong pelvic floor, because it's attached to our spine, it also gives us stability of the spine. This is where yoga and Pilates is really good, because it kind of strengthens all this area, so it keeps our spine intact. And again, really, I feel that sexual function in women is really important, not just for a happy relationship, but also general well-being. Women who are sexually active and have a kind of enjoyable and active sex life tend to be happier and do a lot better. And then it also supports all our abdominal and pelvic contents, because it's attached to all these kind of bones in the front and bones in the back. So it kind of keeps everything together. Okay. I seem to have lost you all. Can you see me?
I can see your screen.
But can you see my face? No, you can't see me. Oh, okay. Right. Oh, there you all are. Right. Sorry about that. Okay. I've never done screen sharing before, so forgive me. Right. Okay. So any questions there? Anybody got any questions to ask me about?
There is one here from Tor Palfrey, it's Victoria Palfrey, saying she had a ventouse delivery with an episiotomy, which she believes has caused prolapses. Does an episiotomy always cause a prolapse, or does it depend on the length of the cut?
Okay, so an episiotomy itself doesn't usually cause a prolapse, but what I mean, it's purely the labor itself will have an impact on the pelvic floor. The fact that you needed an assisted vaginal delivery, be it ventouse or forceps, could be due to a prolonged labor. You've been pushing for a long time. So the length of the time that the baby's head is actually on the pelvis is important. Ventouse is a much more gentle instrument to mum. It doesn't cause as much pelvic floor damage because sadly it's not as kind an instrument to the baby because it sticks onto the baby's head, so the baby can have more complications like hematomas, bleeds in the top of the skull or the eyes because of the pressure. So a ventouse doesn't cause as much damage. I would probably suspect it's the pregnancy, the childbirth, the reason why you had a ventouse are the more contributing factors. An episiotomy does cut through two muscles, which is the transverse perineal muscle. So we intentionally cut this muscle here, if done correctly, and this superficial muscle here. But I'm not aware of any studies that would say that the episiotomy itself is a cause for prolapse, and it would be very difficult to pinpoint prolapse on an episiotomy alone.
I guess logically, though, you'd think that, if you've cut through muscle, it's going to make that pelvic floor weaker, isn't it, really?
Oh.
So I guess that by logical extension, you'd think it could be a contributory factor.
Yeah.
The other thing I was going to ask about was constipation and bowel movements. Do they contribute as well as a risk factor?
Oh, definitely. So again, anything that could potentially would make the pelvic floor inactive or weaker. It's the same concept again as yesterday, and I suppose not everybody who's here today was here yesterday. If you are constipated, you cannot contract the pelvic floor adequately. In fact, I had a consultation with a young lady today who had had a hysterectomy for something else, nothing to do with prolapse, and after the surgery, she was in quite a lot of pain, lots of painkillers, cocodamol. Codeine itself is a constipating agent, so just be, we need to be mindful of that. And that led to severe constipation where she may have been opening her bowels once a week, or if that at the most. So, and that stool has the weakest point where it's going to protrude towards the vagina. So it will herniate into the vagina and form what's called a rectocele. So that's the lowest type of prolapse you can have on the posterior wall of the vagina. So constipation is a big contributing factor. And although this lady was absolutely devastated, wanted a quick fix, wanted to have surgery to correct the prolapse, it's not the right thing to do, because if I were to operate on her tomorrow and she's still got constipation, she and I are going to be back to square one. And you want your first surgery to be your most successful surgery. So education, rehabilitation, working on the pelvic floor before any form of surgery is really important. And although in this day and age, we like a quick fix and we want to get rid of the bulge, and, we're all in that mindset of let's do this quickly, but it doesn't pay off in the long run. So rehabilitate the pelvic floor, education with what, getting on top of the constipation is really important before any form of pelvic floor surgery.
Good. Yes, because I remember mentioning to you a while back a family member of mine who has a grade 3 type prolapse, who was instantly told that surgery was her only option, to which I sort of nearly pulled my hair out and was like, no. So basically, generally speaking, I love to chat with you, but I don't want to go under a table. So how do we avoid actually getting to that point where we've got a type of prolapse that is going to require surgery? Shall we grade them and explain how we avoid going under your knife?
Yeah, we can. We'll go back to my screen. Let me share this. Right. Okay. So let's think about the prolapses themselves and what are they, and then how do we prevent this from happening. So this is a nicely toned pelvic floor. So you've got a good tone there. Obviously, when you open your bowels and you have open your bladder, this will descend and then come back up again. A droopy pelvic floor is where you've had damage to the muscles or to the nerves, which will lead to a hammock style pelvic floor. And there's different types of prolapse, and I'll come to each of one of these in detail. So this is our normal anatomy. You've got the urethra, the bladder, the vagina, uterus here, and you've got the rectum. A drop of your bladder into the vagina is a cystocele. It's the commonest type of prolapse we come across in gynecology, and the most difficult one to treat. And I believe the reason why it's the most difficult one to treat and the most likely to fail is because the bladder sits on top of the vagina. So as it gets heavier, gravity will dictate that it drops down. So cystocele is most common. We then have a rectocele, which is when I mentioned if you have bad constipation, poo collecting in the rectum, it pushes into the vagina. And here we've got the womb itself can come down, uterine prolapse. As you mentioned, Fiona, 40 to 50% of women will have a degree of prolapse once we go after the age of 40, and the lifetime risk for surgery is about 11%. And you know, prolapse surgery is probably one of the most common surgeries that we do. And as we once you've had prolapse surgery, the risk is also there that you may need to have it again. So prevention. The most effective way to reduce your risk of having prolapse is to be on top of the pelvic floor. So pelvic floor muscle training, learning how to do it from an early age. Pardon?
Ladies, if you haven't muted your mics, can you put them on mute? Because they're overriding Nadia.
Sorry. I thought somebody asked me a question then. So pelvic floor muscle training is really important. Making sure that your weight remains kind of with a BMI less than 30. HRT, so estrogen replacement, is good for the pelvic floor, and I would recommend using topical estrogen, which has a better impact than oral estrogen. If you smoke, smoking isn't great for the pelvic floor because, as we mentioned yesterday, it can lead to coughing, and coughing has then an impact on prolapse, and as I mentioned, constipation. So these are the kind of main areas what you can do to try and avoid prolapse from happening. And the obvious one is either not to have babies or not have a vaginal delivery as much as possible. So how do we approach a prolapse? Well, I would personally say no symptoms, no surgery, but you can certainly do something about it to help keep symptoms at bay and not get any worse. So it's not uncommon for a woman to go to the surgery to have her smear done by the nurse. The nurse takes one look and says, "Oh my gosh, you got a massive prolapse here," but the woman herself has not felt anything. And because the nurse has seen something, they then get referred into gynecology, and that leads to a whole rigmarole of intervention. And I would personally say is that if we could educate as many women out there about prolapse and to be aware of what they can do to help their bodies, then it won't get to the stage of going into secondary care, because unfortunately, once you hit secondary care, you may see somebody who says, well, we can easily fix that with surgery. You can have surgery. The woman never had symptoms before. You end up with surgery, and about 20 to 30% of women who have a surgical correction of their prolapse, their anterior wall, actually become incontinent. And it really does bug me when somebody's done the surgery to repair the prolapse. Yes, it's not a difficult operation to do, but didn't warn the woman that they could potentially become incontinent. And it's not uncommon. I hear a lot of women say to me, if only I'd known that this was going to happen, I would never have had the surgery in the first place. So no symptoms, no surgical treatment. But I would say if you want to make sure that you don't develop symptoms, then you go down the prevention route. You're aware of it, you're very mindful of what's going on in the vagina, and you tone it up with pelvic floor exercises, avoiding constipation. Okay. If you sometimes some women are not aware that they do have symptoms, but they haven't linked it to the possibility of a prolapse. So as I mentioned, that dragging sensation at the end of the day, where you kind of have that heavy feeling in the top of your legs or a heavy sensation in the vagina. And I met a lady who came to see me about 4 years ago. She became my patient, and she was referred by the GP with prolapse, and they found the prolapse and then referred her to me. And obviously, when I started going through her symptoms, do you have an overactive bladder? Do you have incomplete emptying? Things like that. It's only then that she linked the symptoms that she'd been having, which she thought was normal because she was getting older, to the prolapse. So we treated her prolapse with a ring pessary, and suddenly she felt massively better. So although I say asymptomatic, if you have been told that you have a massive prolapse, get seen, but certainly don't jump straight onto the surgical route, because it's not always the best route.
If you've been told that you do have a massive prolapse, and sometimes it can be more than one as well, kind of, so the bladder can be falling into the vagina, the uterus could be falling out of the vagina, the rectum could be falling into the vagina. Lucky, lovely things. Does it help, even if it is a sort of grade 3 or grade 4, to actually start doing those? But can you bring it back? Can you regain some control and bring yourself back from a 4 to a 3, or a 3 to a 2, or is it a fait accompli that once it's gone past there, it's just done?
No, I mean, you can certainly start doing pelvic floor exercises to stop the prolapse from getting worse. But I would say if you've got a stage 2, so 2 usually means that the prolapse is still within the vagina, but has reached the opening of the vagina, what we call the introitus. Anything that starts going outside the vagina, beyond the introitus, is a stage 3. And if your whole womb or your vagina looks like it's completely hanging out, that's a stage 4 prolapse. Sometimes stage 4 prolapse is very difficult to get it back to a stage 2 or even 3, but you can use a ring pessary to push the prolapse back up. And what I found with women who've been using ring pessaries for a long time is that the prolapse will change. It may have been a stage 3, but because they've been using the pessaries, they've been toning up the pelvic floor, doing the exercises around the pessary. We take the pessary out, and sometimes they'll have a bit of a break. So they may go without a pessary for about 3 to 6 months and actually feel okay, because the vagina has kind of molded itself in shape around what the pessary was. It does tend to come back, but you do give yourself a bit of a break, known as a pessary holiday. So certainly, I think it's always worth trying a pessary. And I have it's really interesting. I have a lot of elderly women who say, I don't want to use a pessary because my mother used those and I don't like them. And I've got very young patients who've seen maybe a gynecologist or a nurse, and they've said, well, you shouldn't use a pessary because you're too young. There is no age limit on a pessary. I mean, most women now are very familiar with their vaginas. You know, it's not taboo as much as it used to be. Especially young girls now, I think, are more aware of their anatomy than what probably my generation were. And a lot of girls are using moon cups, so they're a lot more comfortable of putting things into the vagina. So when I see a young 18-year-old who's had a baby, who's had prolapse, there's no way that I would want to operate on an 18-year-old, to be honest with you. So when I'll say, look, let's use a ring pessary to help with this prolapse, and they're like, you know, really? I'll say, well, do you use a moon cup? Well, no, but some of my friends do. I said, well, just, you know, psychologically think of it as a moon cup. That's what it is. You're just popping a moon cup into the vagina. So yeah, pessaries
especially important, I think, though, because It's around about, according to the stats, anywhere between 10 and 35% of people who have the surgery end up having to have a second one. So, the longer you can go without one, or if you can avoid one at all by using something like that, that's got to be a good thing, surely.
Yeah, so the stats is with the traditional what we call native tissue repair. So we're not using any mesh or anything in the vagina to help correct the prolapse. The success rate is about 85%. So 15 to 20% will have a failure around 5-year mark. So yes, I would agree. If you can avoid pelvic, prolapse surgery for as long as you can, great. But I also have another flip side to the coin, is that if you are a young woman and you've got a totally gaping vagina, you have no sensation with sex whatsoever, you've got a bulge hanging out there all the time,
You've got to
maybe
do something.
it's not a bad idea to have your surgery at a younger age to enjoy your vagina as long as you can and avoid having a baby vaginally. So I have an open mind. I don't think age itself is a limiting factor both to pessaries or to surgery. I think every woman is different.
Exactly. And with the pessaries as well too, I'm assuming that it will, if you've got sort of bladder leakage or fecal leakage, it would also probably be cost saving in terms of not having to wear continence pads.
So with regards to the leakage, if you have especially anterior wall prolapse, as I mentioned earlier, you may not have any leakage because you have a kink in your urethra. So if I show you the what it kind of looks like here. So let's go to the types of prolapse. So anterior wall prolapse here. When you have an anterior wall prolapse like this here, what's known as a cystocele, you have a kink in the urethra. So when you cough and you sneeze, you may not leak because there is a kink there. The other symptoms that you'd experience is maybe incomplete emptying because you've got this bulge hanging into the vagina, which kind of is a pocket for urine to collect. So you never feel like you've emptied your bladder completely. Or when you stand up, the pure movement of standing leads to this area moving in its shape and you start trickling or you start dribbling. So those are common symptoms of a cystocele. And actually, sometimes some patients say to me, I'm busting to have a wee. I go to the loo, I pass very small amount of urine, but if I put my fingers in the vagina and push it back up, I can empty my bladder properly. So a pessary would be really useful. So this is what kind of the most, as I mentioned, the most commonest form of prolapse is a cystocele. It's the most difficult to treat and it's associated with voiding dysfunction. Voiding dysfunction means an abnormal voiding habit. So when we straighten out that pelvic floor and we use a ring pessary in the vagina, that kink is no longer there. And what may reveal itself is stress incontinence. So you may not have had the stress incontinence before, which is the leakage with coughing and sneezing, but once I've corrected that kink, you develop stress incontinence.
Oh, that's interesting. Is a sign of not, for cystocele, would increased UTIs be a symptom as well?
Yes. So if you have a bulge here where there's stagnation of urine, that is a good culture medium for bugs to grow. So recurrent bladder infections could also be a subtle sign of an anterior vaginal wall prolapse. So correcting that prolapse with a pessary helps. Also, having a cystocele, if you may recall, I spoke about the three main different types of incontinence yesterday. One of them was urgency and urge incontinence. If your bladder is not getting emptied properly, your bladder will obviously want to contract to release more of the urine. So it has to work that just a little bit extra harder. And you will develop an overactive bladder. So it could be a sign as well of a cystocele. So recurrent so anything that's related to your bladder function, recurrent infections, an overactive bladder, not feeling that you're emptying your bladder properly, terminal dribbling, leakage at the end, what we call double voiding, where you've had a wee and you think, oh, I need to go back again, and you just sit down again and you still pass a little bit of urine, are all signs of a cystocele. Okay, and the commonest pessaries that we use is this one is called a Goering, which is good for an anterior wall and a posterior wall prolapse. So this diaphragm area here would sit towards the cervix. We'd use a normal ring as the one that I just showed you here. So a ring pessary is also useful for an anterior wall, and sometimes I've used a cube. So especially women who are very athletic or they don't like that bulge there all the time, this is the cube pessary, or the, yeah.
Oh, that's the one that I think looks like a cat's toy.
Yes, yeah. So the cube has got little kind of little holes in it here. These are like suction, so they kind of suck onto the vaginal walls. You pop this in before you go for your workout or your run or something, just to give you that additional support. They've changed the design of this now. This actually is a bit shorter and it kind of looks like that. And that's purely to guide yourself to get hold of it. Just gently pull it down so that you can squeeze it out of the vagina. These need to be removed daily. Whereas this pessary can stay in the vagina up to, we don't like it to stay, I personally don't like it to stay in for more than 4 months without kind of maybe just to take it out, wash, clean, and have a look at the vagina and pop it back in again. But in COVID, we've had a few patients who've had these in for about 9 months. And majority,
we're not taking them out at home every so often. I mean, wouldn't you take it out sort of once a week and give it a good wash? Or
some women don't. I mean, some women have got arthritis, or just it's just not, you know, it's challenging to actually get down to the vagina to take it out. It's not always very easy to take them out. So I've got some patients who've had them in now for 9 months, and I've been kind of giving them virtual calls and they're still okay. So it's quite interesting that the vagina is quite resilient.
That's true. So can I just take you back for a minute, because there's a question here that I missed before, because the chat disappeared, but I've now managed to work out how to get it back. The ventouse, is that the same as a vacuum extractor?
Yes.
All right, that was a question. There you go.
Yeah, it's the same thing. So coming back to our different types of prolapses. So we've covered the cystocele. Now, if you were to have surgery, just something very simple, it's not a difficult operation to do, I must be honest. I mean, as somebody, I love vaginal surgery. I like putting the vagina to look exactly like it looked before having a baby. And my theatre team are always laughing at me because I'm like, come and look at this vagina. It just looks so amazing after I've operated on it. But we just take this bulge here. We put some local anesthetic. You're obviously asleep for the majority of the times, but we can actually do this under local if you know, somebody really wanted it to be. We make a little incision into the anterior wall. We find the bulge, which is the bladder. Okay, so we have to be careful that we don't actually injure the bladder. We push the bulge back to where it should be. We kind of reinforce the muscle, well, I do anyway, I reinforce the muscle layer below the bulge. This is in the days where mesh was used. People were placing mesh in that area, and then this excessive vaginal tissue where it's just stretched is removed, and it's then closed back up again. And this is called a native tissue repair. So that's the anterior wall where we have a cystocele. The next two type of prolapses, which is on the posterior wall, the back wall, this is an enterocele, commonly seen, most commonly seen actually after a hysterectomy. I haven't come across many enteroceles in my career where somebody hasn't had a hysterectomy. And this is a rectocele, which is the rectum. So the symptoms, if you were to think, well, do I possibly have an enterocele? Quite interestingly, the symptom that women tell me is that they feel like a gurgling or a movement in the vagina. And that's because what drops into this prolapse is actually small bowel. Now, small bowel is very active. It's always moving. And so they get this feeling of gurgling and movement in the vagina. So that's a sign of an enterocele. And a rectocele is where you get this large bulge, and commonly the symptoms that you would feel is that you find it difficult to open your bowels. So you feel like you may have you're about to have a big stool motion, but only a couple of droplets or pellets pass out. But you can still feel it there. And if you put your fingers into the vagina, you'll actually feel the bulge there. And if you push down, which is commonly called splinting of the posterior wall, you'd be able to evacuate. And another interesting area that a lot of women have to push, and I mean, I'm not embarrassed to say I've had 3 cesarean sections. I have not had a baby vaginally, and I have got a mild degree of erectocele. I have to push this area, the perineum, so the area between the back passage and the vagina, because there is a bulge and there's a bit of a weakness there. And if I don't do that every time, I may not be able to feel like I've emptied my bowels properly. And there is no harm in doing that. You're not going to injure your vagina or do anything to harm it. And there's quite an interesting device for women who've got a rectocele. This is called a FemEase, and it was designed actually by a nurse. I think the company is D. Smith Medical, and you would basically, it's like a spoon, and you would hold the top part and put this part, when you feel like you need to have a bowel motion, you'd put this part into the vagina and kind of very gently push down, and that straightens out the posterior vaginal wall and allows you to have a bowel motion a lot easier than straining.
I ask 2 questions here.
Yeah.
But one of them is just going back to the enterocelia, and I guess people who've had a hysterectomy, can you use a pessary if you don't have a cervix? Was the question.
Yes, definitely.
Yep.
So for women who don't have a cervix, I would maybe, and especially if you're very ambidextrous, so you can, you're athletic, you can use the cube. This is one of the smallest sizes we have. It goes up to a size 8. I think this is a size 1. So this is actually tiny. You can use a cube. It has excellent suction on the vagina to push everything back to where it should be. Or if you're not sexually active, you can use one of these, which is called a Gellhorn. Now, a Gellhorn, sorry, is quite useful. These are the ones, I do actually have quite a few patients who use these themselves. You would squeeze it, pop it into the vagina. This knobby part would be towards the outside. And when it opens up, it keeps the prolapse back to where it should be. But most women don't usually have sex with these in because it's not traumatic, but it's just in the way. And in women who've got a kind of stage 3 prolapse with a cervix, i.e. they haven't had a hysterectomy, sometimes I've used this if a ring has failed. So you have to have a degree of tone within the pelvic floor for a pessary to stay there. If you've got a completely knackered pelvic floor, that there's no tone, there's no strength, you can't actually feel a pessary in, that's usually a common reason why pessaries fall out. So Fiona and I were chatting before this talk. We were saying, well, what can we do with women who've got a degree of lack of sensation, whether it be due to kind of short muscles or a degree of pudendal neuropathy, where the pudendal nerve is damaged. And the pudendal nerve is the main nerve supply for the pelvic floor. So if that's been injured, be it in childbirth or due to spinal trauma, then you may want to use some of the novel techniques, such as sitting on a chair. So there's now these novel treatments like the magnetic chair or Emsella chair, which are external devices that activate the muscles because you can't actually feel them. The woman cannot feel the muscles. So, I feel so it's bad when sometimes I see women who've had really kind of difficult deliveries and they just can't feel anything in the vagina. I've got one patient who's got no sensation whatsoever. And if you can't feel anything and you can't work the pelvic floor, then the muscles actually get weaker with time. So some of the novel techniques I think are quite interesting, exciting. I'm certainly somebody who's looking at this field to particularly use in my patients who I suspect have had a degree of pudendal neuropathy due to childbirth.
Yeah, that's it's quite a number of people who have had, and yeah, not an easy life for people when they've had that. So that's an interesting one, and we'll spend that. Shireen will be doing quite a lot of that on Thursday night. She'll be going through each of these ones, different, because laser as well, the radio frequency, which you've got a radio frequency machine as well, haven't you? Looking at those types of things. Back to the rectocele for a minute. If would it also help, apart from the little spoony type thing to hold the rectum up, to have the squatty potty, to have your feet up above your knees, so your bowel is in a better, easier position to poo in?
Definitely. So stool habits and how we evacuate our bowels is really an interesting topic. So when I was younger, my father's Arabic, my mother's Welsh, and my dad took us to Baghdad when I was about 7 years old. And we as children were absolutely horrified. And my mother was horrified that there was this hole in the floor that we had to wee and poo in. And I remember my 3-year-old sister at the time did not have a poo for probably 2 weeks until my dad bought a toilet and actually put it on top of this hole, because she would not, she just would not sit in this thing. She had this total fear that she was going to go down the chute. But actually, in reality, that is the best way. I mean, constipation is probably unheard of in the Middle East. And purely it's because our knees, when you squat, your knees are at a level above your pelvic floor. Your abdominal wall muscles are relaxed and your bowel is actually straightened. So the poo just slips out, so it's kind of like no effort. So squatty potty is a real interesting concept for everybody. And I would recommend that everybody gets a little stool, go to IKEA, buy it for £2. I don't know. I've got stools in every single toilet here, and it's color coded. The boys have green and blue, and the girls have pink and white. And encourage your children really early to put their feet up on a stool. Give them a little magazine or a storybook in the toilet. And having a poo should be a relaxing thing, not a hurry thing, because then we actually don't work the pelvic floor properly. And the other thing is that actually evacuating your bowels with the exhale rather than an inhale. So, it's not pushing down, it's actually with the exhale, the bowels relax. And a really interesting point that I kind of picked up from the pelvic floor forums was flaxseed. So adding flaxseed into your diet really helps with women who suffer with a rectocele, because the seeds themselves, they break down and then the oil will coat the stool, so it allows it to kind of evacuate a lot easier.
Oh, that's interesting. I have been adding flax seeds actually, but they're ground to my muesli in the morning, and I can't say I've noticed any difference as yet, but there you go.
So you can buy whole flaxseed from Holland and Barrett, and I sometimes will add it to salads. I'll add it to porridge, but I'll also put it to rice, because being half Arabic, we do love rice. So I'd make the rice, and then I put a big handful of flaxseed into the rice, and it's quite good. Turmeric as well is really good for you, good for your bowels, and good for your general health. So all of these things are good.
Excellent. Good. You mentioned vaginal laxity there as well. Is there anything, why does that happen, and what can we do about it in terms of, obviously, I mean, if we've got things that are falling into the vagina from either side and above, then the strengthening of those walls is kind of important. So does laxity play a role, and what can we do about it?
Yeah, so vaginal laxity is definitely a thing. And I personally feel it's a variant of prolapse, and it's just the vaginal walls. You've had a baby, it's going to stretch, or even the pregnancy itself. Progesterone has a large role to play in relaxing the pelvic floor. So laxity is definitely something that I think women find it difficult to vocalize what they're actually feeling. But I feel that the things that I hear and I gather is that sex just doesn't feel the same as it used to be. And that's because the vagina has stretched, so there's a laxity in the walls, and the woman herself feels that there's hardly any tone. So she feels that there's a prolapse. We'll go to see a gynecologist who says, well, your vagina looks completely normal, there's nothing wrong with it. I personally feel that you just need to take some time. So I will examine women. If I'm lying down and you can see an obvious prolapse, then great. But I'll also examine them in left lateral, standing up, doing all the things that makes them feel that they've got a prolapse. And, I'm never surprised, but sometimes lying flat, there's nothing. You can't see the prolapse at all. But once they stand up and you deactivate the muscles of the pelvic floor, and certainly get one leg up, so you kind of inhibit the pelvic floor from contracting, and then you ask them to bear down, you can actually feel and see the prolapse. So as I said,
probably not the most dignified of examinations for the woman, really.
No, but as I explained to women, you're here with me for a very short time, so I'm going to try and do as much as I can to establish what exactly is going on with your pelvic floor, and I'm sure most women would rather have somebody listen to what they're saying and have a totally thorough examination than have a half-hearted examination and be told that there's nothing wrong. So with regards to vaginal laxity, the treatments that we offer, again, is pelvic floor muscle training, exercises, estrogen into the vagina to help increase your basal layer. Certainly women who are breastfeeding, lack of estrogen can contribute to that. And so I have no qualms about putting breastfeeding mums onto estrogen as much as they want. That helps to build up the vaginal tissues. If there's evidence of kind of a gape in the vagina, but there's no obvious prolapse, then we may need to bring the levator muscles back together. So we'll do what's called a levator muscle plasty. So we're tightening up the vagina surgically. But now that we have these novel techniques like laser or radiotherapy, those help to rebuild the collagen layer, which may help with vaginal laxity rather than going down a surgical route. So there is other things now that are out there.
Yeah, and I guess that goes back to the question I had before about bringing you back from a 3 to a 2 or something like that they might be vaguely helpful, possibly. When it comes to surgery then, all right, so we've got different types that you just sort of touched on them, and basically we're either slinging things, we're suturing them to the back of the wall. What are the options there, and what are the if we're coming to you, what are the questions that we should be asking about this, about how we recover and what we do to avoid having to go through this again?
Right. Okay. I think I've got a few things about surgery here as well. So, right. Surgery, as I said, posterior wall repair is exactly the same as the anterior wall repair. With an enteroseal, there are other things that we can do. We can do something called, well, I'll actually go through here a bit later. Is anybody okay with pictures? Because I've just got a couple of pictures here. If the prolapse is completely hanging out, then there are two options here. You can have non-uterine preserving surgery or uterine preserving surgery. So if I see a very young woman who's in her early 30s, whose family's not complete, but the whole cervix and the uterus is hanging out, well, obviously in that lady where her family is not complete, I wouldn't say it's the best thing to do to have uterine preserving surgery, but that may be the only option. So we could do something that's called a sacrospinous hysteropexy, or where we actually kind of attach the cervix to ligaments within the pelvis. Some women, if they've got heavy periods, they've still got bleeding, or indeed if there's a suspicion of cancer within the uterus combined with a prolapse, then I would do a vaginal hysterectomy, or I tend to do most of my surgery vaginally, so vaginal hysterectomy. This is a sacrospinous fixation or a sacrohysteropexy. We go into the vagina. There's kind of ligaments here inside the pelvis. This is a whole vagina that's hanging out here. And one of the treatment options is what we call a colpocliesis, which is actually closing the vagina. So this is not something that I would offer to a woman who's sexually active. It tends to be more in our elderly population, maybe women in their 70s or 80s who may have had repeated surgery before, have just had a guts full of having the prolapse. They've been using rings or pessaries and nothing is working, and they've kind of had enough. So I would discuss with these women colpoclesis, which is closure, total closure of the vagina. But
can that be done partially? I mean, does it have to be done at the top so you couldn't have sex? Couldn't it? I mean, at the could it be done at the distal end rather than the proximal end? So you could actually have sex?
No, unfortunately, you do have to close the vagina. But I tend to modify my technique so that when you look in a mirror, it looks as if your vagina is still there, but actually, literally, as you go in, maybe a centimeter or two inside, it's closed, and that is the whole point of a colpoclesis. If you are sexually active, there's no way that I would offer anybody this kind of surgery. This is really for the non-sexually active woman. Like a lot of some of my patients are quite moribund. They're in, they're in wheelchairs, or they're disabled. They're in bed and nothing is working. And obviously, if you have a vagina that's totally hanging out like this, it affects your bladder function, as you can see here. I mean, I put a catheter in here because I'm doing the surgery, but some of these poor women can't actually pee because that urethra is totally kinked out. So the bladder is actually down here. And so in these women, it is a good option, and there's the satisfaction rate is well over 90%. So it works really well. This is the days of mesh where we would do a sacrohysteropexy. So maybe in a very young woman or a very elderly woman who, we don't want it to fail. This is the womb here, the cervix, these are the ovaries. This is looking at from inside by keyhole surgery. And we've got a mesh just here, and it's attaching the mesh around the cervix and putting it up to the spine. But not many people do that now. And
So
as
there are a couple of options there. You're either going through the vagina to get to where you need to go to, or you're doing keyhole laparoscopic surgery to get to where you're going, rather than giant abdominal chopping you open and laying it all bare.
Yeah,
So
I mean, to be honest with you, I'm not aware of, I mean, certainly in Wales. Wales is a small country, so we all know each other. I'm not aware of anybody anymore who's doing any form of mesh surgery. I certainly am not doing any at all. And I think the last time I did one of those operations was back in 2015, so nearly 6 years ago. And now, if somebody were to come to me and say, I'd like to have a mesh procedure, I wouldn't be comfortable doing it because I haven't done it for 6 years. So I'm not as good as somebody who's probably doing it all the time. And that's also something to bear in mind when you go and see a gynecologist or a urogynecologist. It's sometimes worth just knowing what is their experience in that area, because gynecologists are different. Some.
And I think they're only really doing it in the emergency case, aren't they? There's just nothing else that can help. I think it's got such a bad rap now that I think that people would run a mile if anybody mentioned.
I mean, if I've got somebody who's got, I don't know if I've shown you these before, but these are called fembrace underwear. And we did have a patient who was quite high risk. There was no way she could have any form of surgery whatsoever. And so her whole uterus was hanging out. So we advised her to buy these underwear, and they do actually work really well. So yeah, they're like a pair of knickers. And then this comes round the waist. Yeah, so it looks like that. And then from the inside, you can actually tighten the support down the bottom here in this area. So you can tighten the support belt. And this is also sometimes used for women who've got bad varicose veins in pregnancy. This helps to support the vulva, so you don't have that dragging sensation within the vulva.
Wow, I mean, I can't say that they're the sexiest pair of underpants I've ever seen, but if they serve the purpose and do their job, that's probably a good thing. There's quite an interesting question here, actually, and that is, God, honestly, I need new glasses, or I just need to wear my glasses. What could be the cause of a vagina feeling closed during sex at times? Not always, and what could cause that type of sensation?
Okay, so if a vagina feels tight or closer, not all the time. Again, I'd want to know what is the age of the person. Are they premenopausal, postmenopausal? Could it be a sign of atrophy? Because again, if the vagina is quite dry, it could be uncomfortable. And so that affects the sensation. And as I mentioned earlier, the pelvic floor muscles are very protective. They want to protect you and protect the vagina. So if there's a lack of estrogen and it's uncomfortable and it's painful, your brain will register that this is painful. So I'm going to close your vagina when you have sex because this is going to hurt you. So it works at a very subconscious level. So, and that's what happens to women with vaginismus as well, is that if they at any point they found that sex is becoming uncomfortable, then they can't actually relax the pelvic floor. So it becomes a little bit more difficult. So what I would do with my patients who have vaginismus is a lot of it also depends on psychology. So I work with a fantastic psychotherapist who kind of gets down to the bottom of what's going on psychologically, because the subconscious mind is very strong. It's like men who have problems with erections, you know, with the best will in the world, they may think that they're absolutely brilliant, but they're so worried about their performance, the size of the penis, what's going on in the background, their stress levels, that they come to do the deed and it just flops and there's nothing they can do about it. It's very subconscious. That happens with women as well. But rather than us having a floppy vagina, we tend to have a tight vagina because it wants to protect us. So I would say if that's happening and you're young and it's kind of seems to be out of your control and it's now and again, then seeing a good psychotherapist would be useful. Having an assessment to do some trigger points in the vagina. Are there any painful areas in the vagina? Certainly lubrication would help. I would not use KY jelly because KY jelly is quite drying to the vagina. It dries it out. So it's okay when you first start, but then it actually makes it dry. So it's not a good lubricant. I would use something like silk or yes, or a plant-based lubricant. Regular moisturization of the vagina. So using a Replens moisturizer every 72 hours. Estrogen cream is usually useful. It doesn't matter how old you are, you can use a lot of estrogen cream in the vagina. And if all of that is not helping and you're reaching a point where actually you still feel it's kind of out of your control, then I would look at using some Botox into the pelvic floor, and maybe then using some dilators. So there's a really good, there's a guy who's retired now, but his name is Peter Pashik, and he's a plastic surgeon from the States, and he's done a lot of work on vaginismus and the grades of vaginismus and the treatment of it with dilators and with Botox. Also, so I see a lot of women who've had a baby and they've had an episiotomy or they've had some scarring in the vagina, and then subsequently sex obviously doesn't feel the same, or they develop a degree of vaginismus. So in those women, I may use some scar breaking down agents like hyaluronic acid or some long-acting steroids into that area. Sometimes I have to remove the scar. And it's quite interesting as we go through the menopause. If you have any scar on your body, you will notice as you start approaching the menopause and going through the menopause, your scar will change. And I have a massive scar that I've got from kind of my mid-xiphisternum to my back, where I had my lung removed when I was 12. And I've had no problems with it for years. And I had to go swimming every day for this scar to stretch, and it's always been fine. And then once I started going through the menopause and perimenopausal, this scar was giving me so much jib. It's affecting my neck. It's affecting my whole side of my body. So I've seen a scar specialist and he's worked on stretching the scar, and I started my HRT and it feels a lot better.
Yeah, so I think a lot of people find that with their episiotomy scars too. And I think they're using the Avestin and really massaging that sort of perineal area is.
And so I now see a lot of women who go through the menopause, even as kind of in their 70s, and it's the episiotomy scar which really hurts and which is a kind of the focus area. So sometimes I don't like jumping into surgery because they've already had a scar there. If I give them another scar, potentially you're kind of just exacerbating the issue. But if everything fails, then yes, I sometimes do have to go in and remove the scar to allow them to form some new tissue. And a novel technique for scars now is PRP. So I hope Shirin may be talking about that on Thursday. But PRP is becoming an area which we're looking at for the to help with scars or lichen sclerosis. So injecting that area to allow new blood supply to come, to allow, for renewed healing.
Yeah, yep. I hope that she will be. I will be asking her that, so I hope that she will, and you'll be there as well, won't you? If you can come and listen, and then you can jump in as well and add to it. We are over time. Is there anything that anybody wants to ask? And then what haven't we covered? I think we've pretty much covered it all, haven't we? I'm just looking at my notes down here when I
One thing I haven't mentioned, which as like yesterday, the red flags, things that I'm really mindful of, is that it's very uncommon to develop prolapse suddenly. So prolapse tends to be a gradual thing that kind of happens with time. If you suddenly have a prolapse, which you didn't have before, and then always make sure that somebody examines your tummy. It's not uncommon that I've come across women who've had a large ovarian mass, which has just gone missed. And it's the mass that's been pressing down on the pelvic floor and causing incontinence. So that's just something that I kind of like to mention.
True. The other thing that I mentioned, maybe because Gabriella is here, and Gabriella is a yoga teacher, and I know you do yoga, and Gabriella has developed programs for bones and different other bits and pieces. There is not just the exercises for the pelvic floor, but should we also be looking at the whole core to keep this together?
Definitely. I mean, the pelvic floor is linked to our core. So Gabriella, you can talk about that probably a lot more than myself. But definitely yoga, Pilates are low impact, but strengthening, toning. And I don't think that there's any other sport in the world that will stretch our tendons and our muscles and keep our joints as supple as yoga. So I'd highly recommend it to everybody. And, again, for those who suffer with arthritis and painful joints or chronic pain, don't let your condition stop you. Sometimes you have to work through the pain to reach a level that you're comfortable with. And there's different types of yoga. So I kind of go between Kundalini yoga, which is about energy, or yin yoga, which is restorative yoga. So if my joints are flared up, I'm like a walking textbook, actually, because I've also got arthritis and fibromyalgia. So I do yoga every day because I feel like it kind of just showing up on that mat is something that makes me feel good. But if my joints have flared up, or I've got sausage fingers and I can't put any pressure on my fingers, then I may change my style of yoga. So I definitely think it's worth thinking about, to start young doing yoga.
Yeah, brilliant. Does anybody have any questions and that we can quickly sort of run through before we go, because we are at now 8:10 and are sort of conscious of the fact that people probably want to actually have some dinner. The other thing tomorrow is vaginal atrophy with Vikram Talalika. So we'll be looking at all of those things. Thursday is Shirin, but please remember it's at a different time. It's at 4:00. And Friday is 1:00 with Fiona, the physiotherapist, who will pull all of those bits together.